Hi, Dr. Wethington.
Hi, Joanne. It's nice to see everybody tonight. Welcome to our introductory webinar, an opportunity to learn about gynecologic cancers, the GYN oncology team here at Johns Hopkins Medicine, and our survivorship program. When people traditionally think about survivorship, they often think of it as something that comes post-cancer, post-treatment, equated with the word remission that a lot of people talk about. But actually the original concept and sort of where our paradigm has swung back to is that survivorship starts from the minute you first hear those words, you have cancer. And it's something that's carried with someone actually for a long time. And many people think actually for the rest of their lives. It was elegantly actually first written about in a New England Journal of Medicine editorial in 1985 by a physician who was a young man and also recently diagnosed with a cancer. And Fitzhugh Mullen sort of crafts and describes what it means to be first diagnosed with the cancer and what it means to be a survivor and sort of his survivorship journey. That concept has grown into a many organization worldwide concept that is carried forth. And our own survivorship program here at Johns Hopkins has many components, from peer support to education to awareness to energetic races that are all geared towards raising awareness for GYN cancers and raising awareness for our gynecologic cancer survivors. In the past, we've had in-person survivorship conferences, and these drew people from more than a dozen states and were wonderful events filled with great education and interpersonal contact. And in the era of COVID, we obviously are no longer able to do these sorts of interpersonal events, but we are hoping that this webinar series instead, a weekly every Wednesday night during September, which is GYN Cancer Awareness Month, will become part of our regularly scheduled programming, so to speak, to invoke a former news reporter. So we are glad that you have joined us. We hope that you enjoy, that you learn a lot. And tonight is really just geared towards introduction. What if we were having a conference you would imagine as that introductory session or that wandering around the halls and meeting people? It's going to be an opportunity for us to introduce ourselves, for everyone who is on to ask questions. So if you are a participant who is listening in and you have a question, you can hit that chat button and join the chat and ask a question, which we'll curate and then pose to the group. But it's an opportunity to sort of set that groundwork, that initial understanding of us and also of GYN cancers and some of the things that we wish our patients knew as they approached a new diagnosis, as they approach ongoing treatment, or as they approach recurrence or that wonderful remission and time period post-treatment. So tonight we're going to start actually with introductions in absolutely no order other than the order that people appear on my screen so that I can keep track. We will start with Brett, who is one of the PAs on our service. Kind of what I've asked everybody to do is give their 1 to 2 minute elevator pitch about them, their sort of professional story, and then give us one fun, heartfelt, interesting factoid that we may not know unless we attended an event like this. So Brett, you'll get to start us off and lead us off.
Okay, I'm regretting being first to the party. My name's Brett. I'm one of the physician assistants with the team. I'm local to the Baltimore area, but I went to Campbell University for PA school, which is outside Raleigh. I work on the Weinberg 4B floor. So when you're admitted to our service, you'll be seeing a lot of me. And I guess my fun fact, I have a sand collection. I collect sand from every place pre-COVID that I used to visit.
That is fabulous. That is a very good factoid. Amy, do you want to go next? Amy Brown?
Sure. Hi, everyone. My name's Amy Brown. I'm the nurse manager on Weinberg 4B, so I work with Brett. I have been a part of 4B when I started here in 2005 as a travel nurse and just fell in love with Weinberg 4B and our patients here that I decided to stay and just kind of work my way up. And actually, Joanne's on the panel, and Joanne was my manager at the time, and then she made the decision to hire me. So thank you, Joanne, for bringing me on board. So I went from travel nurse to staff nurse. Anyway, a fun fact about me is that I'm a Maryland native, but I used to live in Montana. So there you have it. and someone's knocking at my door. So I'm at work right now, so I'm gonna mute myself, and I didn't time that. I didn't plan that, but I'm gonna mute myself and see what's up. So take it away, whoever's next.
So a very real interaction. We actually have a couple of people who are going to be popping on and popping off because they are similarly taking care of clinical duties. So you'll see that happen a couple of times. But Dr. Ferris, do you want to go next?
Sure. My name is Stuart Ferris. I grew up in Louisiana. I've lived in, Texas, Virginia, Pennsylvania, and now Maryland. I joined the Johns Hopkins UI Oncology group a year ago, and I'm in charge of the fellowship program. So the physicians who have completed their residency in OBGYN, who are training to do what we do, is to take care of women with gynecologic malignancies. I am in charge of the program that gets them through their 3 years. So that is my role here, in addition to taking care of patients, surgery, and chemotherapy. And let's see, my fun fact is I'm an amateur baker. And pre-COVID, I would bring my work to 4B for people to share, but we've not done that since COVID, which is very unfortunate, and is likely the result of my personal COVID-15 that I'm sure everyone is aware of. So.
Those are great facts. Dr. Beavis, would you like to go next?
I'm Anna Beavis. I've been at Johns Hopkins for over 5 years now. I trained here in my fellowship and then I stayed on. I'm originally from England. That usually comes up at some point, a few sentences into chatting with me. Let's see, in my role here, I'm one of the attendings, but I also split my time about 50-50 between research in cervical and endometrial cancer and clinical care. And I'm currently working on some grants to fund some more programming for us in our clinic, as well as some kind of research into those two cancers. My fun fact, Dr. Wellington stated it beforehand, so I'm going to use it, which is that I biked to my wedding, but I also bike to almost every surgery that I do because it's good for the environment, it's good for me.
Fabulous. I love that fact, so I'm glad you mentioned it. Dr. Stone, would you like to go next?
Hi guys, I'm Becky Stone and it's great to see everyone. I am the current division director for the Kelly Gynecologic Oncology service, and as you guys I'm sure know, have huge shoes to fill following Dr. Fader and Dr. Bristow and Dr. Motz, and obviously Dr. Kelly who came before, and you know, really feel very motivated to deliver on, you know, our promise of taking care of the women and their families that we love, and that is really our number one mission, is patient care and service to our patients. And I think that, you know, we have just an incredible team. I actually think we have the best team that exists anywhere, and I am always amazed by them. And I really think, you know, an example of what this team is able to accomplish. You know, we were able to, you know, witness and be a part of us as providers and many of you as patients, you know, over the last 6 months, you know, during a global pandemic. All of these people on this call here kept, you know, our service line going the entire time, which meant that we did, you know, over 100 surgeries for patients, including radical surgery during the peak of pandemic, the 8 weeks of peak, and gave over 200 cycles of chemo and saw over 1,000 patients just in those 8 weeks. And so that is this team, and I am just so, I feel so blessed to be a part of it. Fun fact about me, I once took my dog to a dog psychic to figure out what type of dog food she liked, and mostly whether she liked vanilla versus strawberry yogurt. I know that seems frivolous, but it actually was very, very informative.
That is perfect kind of fun-filled fact we were looking for. I mentioned earlier that there's some people who are going to be popping on and off because they're taking care of clinical things, and Dr. Levinson is one of them. So I'm going to go a little bit out of order if other people have the same order on their screen as I do, but that's why, because they want to capture her before she has to disappear back into the hospital. So Dr. Levinson, do you want to introduce yourself? We've been doing—
Yes, thanks so much. I'm sorry to pop in, but thanks so much for having this. I think it's so wonderful. And I'm Kim Levinson. So I have been at Hopkins for a very, very long time, actually, because I actually did my medical school at Hopkins and then my residency at Hopkins, and took a short little break to do fellowship elsewhere, but then came back. And so couldn't stay away. Currently, I am the director of our sister site over at GBMC, so our KGOS extension, and I'm out there with Dr. Lou, who you'll hear from, and loving it. So my passion is in cervical cancer research as well, in addition to the clinical work that I do. So my fun fact, I guess I've been known to at least once a year pick up and do a random triathlon. So that's my little fun fact.
That is an energetic fun fact for us. Dr. Lou, do you want to go next, actually, and follow Dr. Levinson, and then we'll sort of have our GBMC cohort?
Great. Can you guys hear me? Perfect. My name is Fong Liu, and I'm the newest member of this awesome team. Just like Dr. Stone was saying, this is such an incredible group of providers that I'm so excited to be joining. I'm coming here from Boston. I grew up in Alabama, and my training has brought me to all different parts of the country, including Massachusetts and California, and excited to be here in Baltimore. My passion is really patient advocacy. I think, and we'll be talking a little bit more about this in terms of what we wish, patients would know coming in. This is part of the series, and I think it's the patients in GYN oncology are what brought me to this specialty. I love taking care of patients through this tough period, and empowering through them through this period. Fun fact about me, I spent some time during medical school in Africa, and I was in South Africa and briefly spent a split second in my car with a baboon because there was food in the car and I had two doors open. And so the baboon was coming in, and I saw that out of the corner of my eye and quickly retreated out of the car. So, fun fact.
And scary fact, all at the same time.
Yes.
I'm glad you got out of the car. Sharon Thompson is one of our nurses and our lead nurse. Do you want to go next, Sharon?
Yes, hi. I'm Sharon Thompson. As Dr. Wethington said, I'm the nurse manager of the nurses that you usually speak to when you call your provider at Johns Hopkins. So that's Nancy and Joanne and Kelly and Dawn. So I am a lifelong Baltimorean. I actually grew up within 1 mile of Johns Hopkins Hospital and lived there until I graduated from high school. And I've been at Hopkins now for 32 years and love it. It's who I am and wouldn't have it any other way. Fun fact is I love to sing. And in my prior life, I was the wedding singer for my church. And I hope everybody has a great time this evening.
Thanks, Sharon. We're going to have you, I didn't actually know that. I think a lot of these other fun facts I might have had a little hint about, but that one's definitely a surprise. So we may be calling on some singing. Dr. Gayard, do you want to finish up for us?
Sure, happy to. I'm Stephanie Gayard. I'm a little under the weather, and so my voice is a little hoarse. Sorry for that, and I may pop on and off as I'm having coughing or sneezing fits. I apologize. I am a little bit different than my colleagues here. Only in name only, I like to say, because I'm a medical oncologist as opposed to a GYN oncologist. And I like to say that really the only difference is that I don't do surgery, and that none of you would want me to do surgery on you. But like my colleagues, I'm very passionate about caring for patients with GYN cancers, and my particular focus is on clinical trials. And for any of you who may ever come to see me in clinic, you know that I will talk your ear off and you will know more about clinical trials than you've ever probably wanted to know. But I'm very passionate about making sure that people are aware about clinical trials and what the role they play in the care of GYN cancer patients. My fun fact is that I don't get much of an opportunity, but one of the things that I like to do in my free time is to churn wood. And what that means is to actually make bowls and things. So here's sort of an example of a bowl that I turned. This is out of cedar. And so it's one of the fun things I like to do when I have time.
I have to say, I could just keep going around and doing more fun facts because these are actually fabulous and wonderful and didn't realize. So I think that's everybody who's actually on. Dr. Fader is, as Dr. Stone mentioned, the prior director of our division and is the one on call right now. And so she is in the midst of clinical responsibilities and so not able to join us. Sharon is on and representing our nursing staff, but as she noted, we have a number of nurses who help and take care of all of our patients and who all of you know. Joanne is quietly in the corner not saying anything, but there's also, as she said, Kelly and Dawn and Nancy. And we look forward in a few months to having a new nurse join us. So if you see a new face around, we are expecting one more person to join us. Brett is on representing our PAs. Adriana is our new PA who has started recently. So I want to mention Adriana also. And then Amy's representing our Weinberg 4B nurses. And there are a tremendous number of nurses and staff on Weinberg 4B who deserve mention as part of our team and who play an integral and critical role in taking care of our patients. So when you come and meet us and you come and see us in the different settings, these are all sort of the different people who you will meet. And Dr. Ferris mentioned the fellows, and training is a critical part of what we do. And we do have fellows, we have residents, and we have medical students at all different levels of learning in their careers. So none of them are on with us tonight, but I just want to mention them because they are all part of our team, and you will meet them and interact with them throughout your care. And this is true of many institutions. So these roles and these positions are very common, that no matter where you end up getting your care, you most likely will interact with someone who has a similar role. So that ends our self-introductions, although I would like to keep going around with the fun-filled facts. What we're going to move on to now is that Q&A and some questions that are often raised in a variety of settings of us, common questions we get. And the sort of title and the lead-in and the point of tonight is to really introduce some of the things that we wish patients knew. So what are some of those key information tidbits that if we could shout them from the mountaintops to our women who are GYN cancer survivors, their caregivers, their family, their friends, to our very broad audience, what do we wish we could tell people if we had a microphone, the page one above the fold of the New York Times? So this part I will not call on anybody, or I'll try not to, but does anybody want to go first? And if so, just speak up.
I'll start. So I would say, if the one headline I would want everyone to know is you're not alone. And I hope that you'll take that away from this session tonight, just to see how big our team is. And this is just like a small part of the team. It's just, you have this huge team of people who are all working, many or most of them behind the scenes, to take care of you. And the longer you're with us, I think you get a better sense of that. But especially when you're first meeting us and you think you're just coming to see one doctor, you're coming to see an entire team of people. And so you're not alone. I think that would be my most important thing.
And then I just want to follow up on that, Stuart. I love that. And I think it's so true. And I think it's important for us also as providers, right, that we're not alone, that we have each other. And that's such a vital part of being, you know, a caregiver, a person who takes care of patients, that we have our team. And I think the other thing, because a lot of patients and their families have had, you know, some experience with cancer before, unfortunately. And the way that it's sort of traditionally set up in terms of the team is that you have sort of separate people doing maybe your surgery and then medical oncology and, you know, sort of all the parts of it. And GYN oncologists are sort of weird. And we're sort of the last holdout, I think, of, you know, this breed of surgical oncologists who is heavily involved and often does a large part of the medical oncology side of it in terms of chemotherapy and maintenance therapies. We can certainly talk about that. We do a lot of palliative care, you know, palliative care. We know a lot of intensive care medicine. And so it's a little bit unusual, I think, getting care from a GYN oncologist, and many, I think, patients and their families aren't really familiar with that type of physician.
I think something that I would say to piggyback both on what Dr. Ferris and Dr. Stone have said about teamwork is reminding also patients that you're part of that team. Your report of symptoms, of concerns are imperative to help us take the best care of you. And you being a part of that dialogue is so, so important to us. And so to really encourage all patients to never be afraid to speak up, to ask questions, because you are just a part, the biggest part of the team, I would say.
And I think to piggyback off of that, one of the things I kind of wrote down was basically, I mean, there are no right or wrong questions. You don't have to ask your prognosis. If you never want to know it, it's fine. If you want to know it day one, that's fine. We have lots of information, and our job is to basically figure out what is the best treatment for you and how do you want us to communicate that to you. And so some people want to know every number that ever existed every single time they get chemo, and some people just want to know that they're doing fine. You know, they don't need the details. So I think on TV, you often see, you know, it's like, oh, I have cancer. How many months do I have to live? That kind of thing. And that is not the reality. It is something that shifts as you're, you know, as you're treating a patient, prognosis shifts. It can get better, it can get worse. And so knowing how you want to be, how you want to communicate, how much information you want to get, who you want involved, you know, do you always want your family there when you're hearing news, whether that's good or bad? I think those are, everyone is unique, and you can have your own opinion about how you want that communicated. And we are here to kind of work with you to make sure every patient gets what they need.
I certainly agree with everything that's been said. I have a little bit of a one-track mind, and it tends to be focused around clinical trials. So my one thing about clinical trials that I want everyone to know is that I think a lot of times people think about clinical trials as something you do after things have not worked. And that's not really the case. And there are situations where the most appropriate thing may be a clinical trial, and there are lots of situations where it's not necessarily the case that a clinical trial is the best option. But asking that question early and talking to your providers about clinical trials and where they may make sense for you early, and getting to know about them. I really wish it was something that just the general population knew was available in terms of their medical care. I spend so much of my time just explaining what is a clinical trial and when might one consider it. And oftentimes I get the question of, oh, well, I should only really do that after I've, you know, had all these other therapies and they haven't worked. And that's not the case. So spread the word. Clinical trials are an important part of cancer care from the very beginning.
I think that's right. To piggyback a little bit. Oh, Amy, were you going to go ahead?
Yeah, if there's time, is there time? Mine rhymes. Mine is do not wait to communicate. And this is for when you're an inpatient, do not wait to tell us when you have pain, when you have nausea, when something doesn't feel right. Don't hold it in and wait until change of shift. Tell us early. If you're at home, and if you're sitting at home after you've been in the hospital or any time and you're having some kind of symptom and you're sitting around thinking, should I call? Should I call? Is this important? Don't hesitate. Don't wait to communicate. Problems are so much easier to handle when they're small than when they're big. So don't hesitate to tell us what's going on with you early on. That's true when you're at home. That's true when you're here on Weinberg 4B. Also, with regard to do not wait to communicate, do not put off those crucial conversations with your family and the people closest to you about what's important to you. How do you define quality of life? And, another fun fact about me is that I have a degree in death, dying, and bereavement. And so I'm very focused on quality of life and how to, for all of us, it wouldn't matter to me if this webinar was for Olympic athletes. Everyone should have an advanced directive. Everyone should have an advanced directive. Everyone should have those crucial conversations with the people they love most. Again, how do you define quality of life? There's Dr. Fader. And, what's most important to you? Okay, that's it for me. I'll mute myself.
I definitely don't want us to lose our train of thought, and I have some thoughts and questions and things I was going to say as they come in, but since Dr. Fader's here and she didn't get to introduce herself before, I'm going to let her go ahead and take a minute. We did a 1 to 2 minute elevator pitch on who you are, what you do with KGOS, and then a fun-filled factoid. Ooh. Do you want a sec to think?
Yeah. Actually, hi everybody. I don't want to interrupt too much. No. I'm Amanda Fader. I'm a GYN oncologist with the Kelly service. I work with all these wonderful people, and I specialize in rare ovarian and uterine cancers, and really enjoy doing research and clinical care for women with uncommon malignancies and helping us give the best state-of-the-art care that we can in a very personalized fashion. A fun factoid about me. I was in a beauty pageant once when I was 18 years old, which is crazy, I know, but
that's a good fun fact, and it makes your AAGL appearance this year make so much more sense. Now I get it.
It was not the highest highlight in my life, but yeah, so that's that.
Thanks for joining us. As I mentioned, a couple of us are coming in and out of clinical stuff, so we'll just flex as things go. So we're glad you had a sec to come by. So I definitely, I think the one thing I always say to patients when they ask, what do you wish I knew, or when I give talks on this topic and have to answer questions, I always say, one thing I wish everybody knew is it's a roller coaster. So many things in our life are like linear paths, and we make plans and then we enact the plan. And the cancer journey, there's many different metaphors that people use. Some people use the fight metaphor. Some people use the journey metaphor. There's lots of different metaphors. And I always think the roller coaster is a really good metaphor, because they're really high highs where you're on top, you're looking at the roller coaster's just sort of cruising and you're enjoying things. And there's sudden drops that you don't expect. And then even when you're down in that valley, there are these sudden peaks again that come out of nowhere. And so I think that roller coaster is something that I always emphasize to people when they ask me, what do you wish I knew? A little bit of, I can't quite predict. And so we're just going to ride a roller coaster together is something. Dr. Liu, you mentioned earlier in your little introduction, you mentioned advocacy and sort of hinted at that was one of the things you wish people knew. Would you be willing to expand on that a little bit? I think it's a great point, actually, that didn't come out in what was said.
No, I think it kind of ties into what I was talking about with the patient being really kind of the most important team member. Because I think throughout this process, a lot of patients just feel like this huge weight has landed in their lap, and it's so overwhelming. And it's really tying into what so many people have said already, that you're not alone, and understanding, you know, part of our job is really to understand the challenges that each patient faces, which is different. And I think that that's where part of the personalized medicine is really just meeting each patient where they are. Because they're coming from all different walks of life. They have different educational, social backgrounds, economic backgrounds, and it's really important for us as providers, as clinicians, to really recognize and understand what each person's circumstances. And only through that exchange of information between the caregiver and the patient are we really going to be able to provide what I think is the best care for each patient.
That is, it's a great way. That's a great way to end that segment. So I have a question that, as everybody was talking, sort of came to my mind, sort of one of those questions of things you wish everybody knew, but like a little spin on it. So people who come to the hospital, they pack their bag. They pack their bag for chemo. They pack their bag when they come to get admitted. And one of the things we actually do as part of our survivorship program, the Kelly's Angels brings actually a care bag to patients when they're starting their chemotherapy. And so we sort of stuff the bag with what we think is of value. But when you have seen patients who are starting chemo, who are going for their first chemo infusion, who are preparing and who are thinking about what to bring, what do you tell people to bring with them?
Photos of people and things and places they love. And pets like dogs.
I say gums or mints, because sometimes the saline, the fluids we give you, can kind of give you a metallic taste in your mouth. So just something to make it a little bit more enjoyable.
Agreed. Lemon drops, snacks, books to read, puzzles, well, they can't bring a friend now, but when they could bring a friend, an iPad, music, movie, whatever will make them happy. Try it all.
And the charger. Don't forget the charger.
I think a pillow from home is very nice, or even a blanket, something colorful, kind of, it brightens up the inpatient room anyway. So that's always nice too.
I was going to say blanket because I'm always cold, and I haven't been in one of those inpatient beds, but the blankets don't look particularly warm.
When you come for your chemo in the infusion center, you need to wear your most comfortable clothes, whether it would be your pajamas or sweatpants or something that's easy to move in and very comfortable.
Okay. So to kind of shift a little bit and answer there's a series of questions along this arising, so I'll sort of summarize it in one question. What does everybody think is the most exciting, and Dr. Gayard, actually this gets a little bit at what you were saying about your interest with research, but what do we think is the most exciting innovation? Either something that has happened in the last couple years or something that's in the pipeline that is starting to sort of percolate up towards being particularly interesting. What do we think is one of the most interesting, important, intriguing innovations in GYN cancer care in 2020?
Yeah, so I think it's a little bit different depending on which disease you're talking about. Certainly the therapies have just been advancing substantially. I mean, I used to put up a slide of, what had been FDA approved over the last 20 or so years. And it used to be like every few years we had something. and it was just not that exciting. We weren't really making that much progress. But in the last few years, there's just been one thing after another, and it's actually hard to keep up with all the changes that are happening, and very, very exciting. And more than that, there are a lot of new clinical trials. There's been a lot of investment, both through the government and through pharmaceutical companies in developing drugs for patients with GYN cancers. So it's exciting. So I think it depends on which disease you're talking about. I think if you're talking about ovarian cancer, then the newest, biggest and brightest thing would be PARP inhibitors. And we've known about them for a while, but they just keep making a splash over and over again. If you're talking about endometrial cancer, then you're talking about immunotherapy. And there similarly, we thought that it was only going to be applicable for a small segment of the population. And now we have it available in different situations. In cervical cancer, there's some very exciting clinical trials that are going on with various different approaches using immunotherapy, and we're just really hoping to see some true advances in that area. And then just generally thinking more about this idea that we've been talking about for quite some time, but haven't capitalized on yet, which is the idea of personalized medicine. Now we are actually getting closer to that, where we can really truly try to identify specific targets for specific cancers that are going to be beneficial. And we're not truly there yet, but we've definitely made great strides, and it's an exciting time for us to have new options for patients. So that's what I'm most excited about.
I think somebody else started to answer also. Did somebody else want to answer?
Yeah, I think I kind of started to answer because I think exactly what Dr. Garrett said, which is like, even 5 years ago, you didn't have these genetic tests that you could do and then have all of these other, all these new targeted therapies. I think the most exciting thing is that it's not just that we can look under the microscope and say, oh, this is the type of cancer, therefore these are the treatments we recommend. We can actually look at the genetics and the epigenetics of the cancer and say, well, these are treatments that we expect to work because of what we see here. And then I also think that immunotherapy is just very exciting. Initially for just specific subtypes of endometrial cancer, but now with the addition of lenvatinib, we can give it, anyone with endometrial cancer can be eligible for immunotherapy, and the responses we see are so, when it works incredibly well. And I think that's probably one of the biggest changes that we've seen.
I was just going to add to more sort of on the front end. I think we know we're starting to learn more and more what we can do in terms of primary prevention of gynecologic cancer. Whether you're talking about the HPV vaccine, which can prevent over 70% of cervical cancers, or you're talking about, really capitalizing on knowing family history and doing genetic testing to talk about, surveillance and or risk reducing surgery for gynecologic cancers. And then sort of in the population at large, sort of this idea of opportunistic salpingectomy, the idea being that maybe all along, much of what we thought was ovarian cancer actually starts in the fallopian tubes, and that when women are finished having children and are undergoing abdominal pelvic surgery for whatever reason, removing the fallopian tubes as an effort or as a primary prevention strategy for ovarian cancer is, to me, the idea of that and what we've already seen epidemiologically when we look at populations that engage in that type of intervention is incredible.
That's a good addition. To go to the subject a little bit of clinical trials, one of the participants on the line actually asked, how do you decide, or who decides, whether you're going to go a standard treatment route or a clinical trial route? Dr. Gayer mentioned probably you know, when patients come into her office, there's definitely a lot of conversation about clinical trials. But how does everybody decide clinical trials, standard of care? What are the considerations, and how do you advise and counsel patients?
Yeah, so I'll feed that one or field that one first. So the way I think about it is reasonable to consider a clinical trial in any situation where standard of care is not optimal. And what I mean by that is if standard of care is going to yield cure of the cancer, then don't mess with that, right? Like, we definitely don't want to mess with something that works and we know is going to work well. So if that's the case, great, go with standard of care. And many times our standard of care are very good, but there are high-risk situations where it falls short of that. And so those are situations where if there's the right clinical trial, you might consider it. So this is where the nuances come in, and trying to choose a clinical trial. You wouldn't, if you're someone who's newly diagnosed, you wouldn't choose just any clinical trial. You would want one that is at least going to give you the standard of care and perhaps add something onto it that may yield additional benefit, right? So that would be reasonable. And then, but there are other situations where perhaps patients have already had the standard of care options, and yet there may be other available therapies, but their benefit is, you know, less than we would like. And so that might be a situation where you consider a clinical trial. And so my main message is it's always worth asking the question. It is definitely the case where you want to do it under the guidance of your physician, who can help tell you whether what the standard of care is the best thing out there, or even if there are clinical trials in that particular area, because sometimes there aren't necessarily always clinical trials for every particular clinical scenario. But asking those questions, I think, is good, and being in a mindset of trying to find out what else is going on, I think is helpful to have early on, rather than leaving it to, you know, down the road. And the one thing I try to remind everyone is that the advances that we have made, so what we were just talking about, these new drugs that are now available and are FDA approved, and the many drugs that have become FDA approved in the last few years, only got there because people were brave enough to enroll on clinical trials. And, you know, we always hope that patients are going to benefit from trials. It is not always the case, but we certainly always learn from the trials that we do, and we make incremental steps forward, and that's how we advance the field.
Along those lines, a lot of patients go to Dr. Google when they're first diagnosed. And so when patients come in and say, I read this on Dr. Google, or I found this on Dr. Google, how do you respond, and what do you advise? What are your top resources? If a patient comes to you and says, I love Dr. Google, but what do you like for resources? Where should I look? What do you recommend?
Are you addressing that to me directly?
No, anybody on the call, anybody can answer. All of us this is such a common question, right? The internet has so much information on it. There's no shortage of thoughts and opinions on the internet, and blogs and resources. And so I think all of us have our favorite resources, probably, that when patients say, where should I look? Where should I go? We sort of say, well, these are my favorite places. Maybe some people say, don't do it. Stay off Google. Everybody has their own answer. So, and there's no right answer, right? So what does everybody say about what does everybody say when people ask about Dr. Google?
I often tell people not to Google, or I will tell them to Google if I know that there's good stuff out there. But I think the Mayo Clinic often when you Google anything, often one of the first things that shows up is a Mayo Clinic link. And often they have, I don't know, their websites are really well written at a patient level. And it's usually pretty basic. And then, you should ask your doctor about XYZ. And then, I mean, Johns Hopkins, of course, has their own as well that are quite good. But I've noticed for diagnoses, I do like the patient communication that you get through the Mayo Clinic website.
And one of the ones that I really like is the Foundation for Women's Cancers, because they do a really nice job of breaking it down, and it is very specific to the questions that patients with these cancers have. They also have lots of great information on clinical trials, and so when someone has gone there, it makes my job easy because they often are coming in already having some information to start with.
I like the CDC, actually, if you can believe it. The CDC has a thing called their Inside Knowledge Campaign. There's a link in it. It's basically a link that sort of, is informative and raises awareness about the 5 main gynecologic cancers. And they have like a million other links. And I think that it is very user-friendly.
And also, I would say the American Cancer Society has very patient-friendly. If you just don't know where else to start, it's a good place to kind of get used to seeing these words and the definitions, and then enough to then move on to some of these other sites that are going to be very specific. I also like the Foundation for Women's Cancer sites as well.
I think patients also like to watch YouTube videos of surgeries, like of laparoscopic and robotic surgery. And I actually think there's some good videos out there, and the AGL, has good surgical videos that folks can watch. So.
Yeah, if I'm doing sentinel lymph nodes on someone for endometrial cancer, I tell them to Google it because it's so cool.
I Google it in the office and show it to them. So even I do the Dr. Google sometimes, I will admit.
I think we all do. It's a good way to start your PubMed search when you're down the rabbit hole on a topic that you want to get more information about. Any other resources people think are helpful or enjoyable for patients? You mentioned videos, Dr. Stone. SurvivorNet is starting a series of videos on different topics, and some related to GYN cancers. So those are quite good. And Sharon, you had some thoughts and suggestions.
We give a lot of the links from the National Cancer Institute to patients. They have a lot of pamphlets on the different cancers, chemotherapy, nutrition, radiation, each of the individual GYN malignancies. And they actually even have some nice publications for dealing with children of cancer survivors and spouses and that sort of thing. So I give those links to patients all the time, and they're available online now. We used to have to order them and, pick up these big boxes full of books, but now we can just give patients links. So that makes it nice too.
Very cool. We're getting close to the end, and so I sort of want to end with like a little bit of a semi-serious question, or more. All of these questions have been serious, but a little more challenging question I think that all of us face, which is when patients first get a diagnosis of their primary cancer, or they get a diagnosis of recurrence, or the chemo's not working. The daytime hours are often spent like very focused on what do I need to do? How do I take care of my physical health? How do I get better? But maybe not so many daytime hours, or for some people many, but oftentimes our daytime hours are very practical. And our nighttime hours, when we're alone or it's dark, are more introspective and can often be very scary. And so I think a lot of patients come into the office and sort of expect us to take care of the physical piece, but then also help them sort out how to address that sense of overwhelmedness that comes with this process, and that sense of scariness that comes with that process. And so what words of wisdom do people share with patients when they say, I got the daytime stuff, but what do I do about the nighttime stuff? What do I do with my worries?
One thing that I have found helpful for some patients is to journal it, write those things down, and bring it with them to clinic and we can talk about it. Or one of the more powerful resources I think we have is the Sisterhood of Caring, where we have patients who volunteer to talk to other patients. And I think you really can't get any better than that.
Yeah, I think that peer mentorship for many of my patients, especially, you know, there's certain diagnoses, let's say advanced ovarian cancer, where, you know, there's surgery and chemo involved and you're looking at 5 or 6 months of treatment. I have, you know, patients who have found other patients who are 2 years plus kind of down the line, and it's really helpful to see someone who's finished and kind of gotten past that finish line of the original, you know, the first preliminary treatment. So I think kind of seeing that there's a light at the end of the tunnel by seeing someone who's gone through it can be really helpful. And Paula Silverman is our survivorship coordinator, and she's wonderful. So whenever patients have any questions like this, I always refer them to her, because whatever you need, she can figure it out, and she has a resource for it. It's incredible, and we are so lucky to have her. She has, I think, changed the lives of so many patients. So I really appreciate that we have her as a resource.
Yeah, and I also want to point out, you know, and highlight some of the work that, you know, Anna is particularly spearheading with our Health Leads program. I think for many patients, right, I mean, this just a cancer diagnosis, it's not just that, it's everything, right? It's expensive. It's how do I pay my bills? How do I eat healthy? How do I even eat? You know, how do I take care of my family, small children, or, you know, aging mother who lives with you. And you know, so we have a lot of resources, you know, more than we ever used to help our patients with this. And you know, one of the main mechanisms for that is, you know, through our Health Leads sort of resource identification program. And you know, they're incredible. I mean, I just personally can speak on behalf of some of my patients, the messages that I get from them about patients who were able to buy Thanksgiving dinner, or, you know, have childcare for an hour or two just to be able to have some time to think, or just things like that. And then the other thing too is, I think sleep is incredibly important. I think we all know, you know, and the fatigue that patients who are getting cancer treatment feel is just, I don't think any of us on this call can even understand that. I know it must be so profound. And so, but I also think that things change, right? And your circadian rhythm changes, you know, at different times in your life and when you're going through different things. And so the idea sometimes, I think that, you know, that how things were for you might be how they are, you know, during different points in the, you know, cancer treatment journey, isn't necessarily the case. And I tell patients, you know, like, I feel like some of my patients lay awake in bed and they're like, I just can't sleep. And I'm like, okay, fine. Like, don't sleep then. Like, get up and do something, you know, write a letter to somebody, or, you know, watch TV or cook, and then, you know, maybe you sleep during the day. I mean, Winston Churchill was like classic for that. There's some brilliant people who have, like, you know, different sleep schedules. You don't have to be like fit into that box of like sleeping from, you know, 10 p.m. to 5 a.m. or whatever. Like, it's okay to like go your own way.
Yeah, and I would say, so just to reiterate what Dr. Stone was talking about, you know, I think a lot of times when you hear the word cancer, kind of everything else falls to the wayside, and you kind of ignore things in order to treat that cancer. And so, you know, initially there's going to be a lot of things that need to happen to get your care taken care of. But then as kind of the dust settles, you want to make sure that you are able to get those rides. And if you can't get a ride to the hospital, we need to know, because that's actually part of your cancer care, is making sure you can get to us, not just giving you the chemo when you get here. You know, if you are having trouble, like Dr. Stone said, with childcare, or, you know, you lost your job and you think you're going to lose your insurance. So these are things we need to know ahead of time, because we don't just want to prescribe you chemo and do your surgery. We want to make sure that we take care of you outside of the hospital. as well as, take care of the cancer. And then one other thing that I think is important is that when you do get through the treatment, whatever that is, it may just be a surgery, it may be a surgery plus chemo plus radiation. When again, I guess the dust settles, you may start to feel things like you want your sex life back and you feel guilty because you survived cancer. So should you want that back? And that's okay. It's okay to want a normal life back, and it's okay to want a normal life while you're being treated. And these are things we want to hear about because we do have resources and we can help.
So what I would say is this is such an important question because it gives us an opportunity to engage in that exchange of information. So what I always try to explore with patients is, yes, cancer is a huge event in their life, but patients have lived through sometimes so many huge events. And what are other things that they have done when these other huge events have happened that have helped them? Whether it's their spiritual community, whether it's meditation, whether it's exercise, what are those things that you're already doing that you know work for you or have worked for you in the past? And let's revisit some of those things. Also, I try to, talk about when we're facing such a huge challenge, let's break it down into smaller pieces. What's the next thing that needs to be done? What's our plan? If it's just, making an appointment with a social worker, that's another piece to bring in that, a lot of times patients haven't ever gone to therapy and there's a stigma around that. So, do we need to do that? Or let's just make the appointment for the scan. Let's go there. And then once we get the scan back, let's focus on the next step then. So those are usually the points that I touch on.
There's a lull and it doesn't look like anybody else has unmuted. And we're actually very close to the hour mark. So thank you all very much. I am going to end with a little bit of, hopefully my screen sharing properly. And just a few little tidbits and then a little bit of closing celebration. So a few little tidbits on the resource front. Everybody mentioned there are a lot of resources here at Johns Hopkins, and our website has a lot of the resources listed on them. Certainly all of our survivorship programming, resources for patients, which has now been included as a Word file that you can download, and that's a living, breathing document, so it will continually get updated. So you can certainly access our website as a starting point for resources if you need resources. Everybody mentioned reaching out to our nurses, to our physicians, to our PAs, to even our residents and our fellows know how to access these resources to Paula. Anybody on your treatment team is going to be able to help you if you have a need. So certainly speaking up, but if you need if you want the privacy of your own home to start looking for resources, we have some on our website, and it includes information about all of our programming. So we do an annual race to raise awareness and to raise money for our research and our fellowship programs and our survivorship programs. We have our conference, which will be coming back in 2021 as we exit this COVID era, we hope. We have the Brotherhood of Caring, which is our support system or support group for the male caregivers of our gynecologic cancer patients. We have our Woman to Woman program, which is our peer mentorship program for newly diagnosed women. And we also do a retreat each year in the summertime. We're not able to do it this year, unfortunately, but we will be bringing that back in 2021. We do a retreat each summer for women who have recurrent malignancy to sort of bring them and their partners, be it a spouse or a caregiver, to talk about what's going on and help them through the process of recurrent cancer treatment. And the last thing I want to end with, we did this yesterday. We kicked off GYN Cancer Awareness Month. It's September, it's GYN Cancer Awareness Month, and we started with a celebration. And we learned something important about Facebook, which is that the audio on Facebook Live when you're wearing a mask is not very good. And so it left something to be desired. And so I want to end tonight on a celebratory note and an emphasis note. And I want to bring us back to where we have come from, because our program has certainly grown. It started with a small number of women who met and had an idea. It started with the vision of Susan and her heart and soul, which she poured into developing this program and establishing it and making sure it had a good foundation. But there are many people who continue to support our program and make it happen. And each year we raise one of these women up with our Survivor Impact and Advocacy Award. And so this year in 2020, we've recognized Rosie Brilliant. And we did this yesterday on Facebook Live, and I don't think the words got conveyed. So to just make sure everybody knows, we raise this award every year to someone. We raise it in memory of Susan. We raise it in honor of all the women who are advocates. And we chose Rosie because she really embodies what it means to be an advocate. She wears her teal nails. She uses every opportunity to tell her story and to make sure that women know that knowledge is power, knowing your family history is power. In her case, that's her story, and that's her emphasis. But each person who has had a gynecologic cancer has their story and their emphasis. And so she shares her story to help others. We hope everybody will find and share their story to help others also. And so I just wanted to say thank you again to Rosie. We are grateful that you are a part of our community, and we are grateful for all that you do. And we are grateful for the ways in which you continue to honor Susan's legacy, and our program does so as well. So thank you very, very much, everybody, for joining us. We hope you got a sense of all of us, both in a clinical sense and in a personhood sense. We hope you took away some important messages, and we hope that we will see you every Wednesday for the rest of the month, or in the recordings that will be available, that you'll have a chance to view them. We'll be covering some other important topics. Dr. Beavis mentioned intimacy. Sexuality and intimacy will be one of our topics. We're going to talk about clinical trials. We're going to delve more into some of the details of clinical trials. We're going to talk about some of the prevention strategies that are available now that both Dr. Stone and Dr. Beavis mentioned. And so we'll be circling around to a lot of these topics. So hopefully we will see everybody again.